来，
Hello, Professor.
Hi,
Hello.
hi, Sobana,
Can
Dr.
you hear me?
Sobanara. Hi, can you hear me?
Hello.
Hello, hi.
It's not loading.
Dr. Sobanara, can you hear me? Hi everyone. It's time to get started with our online meeting.
Yep. Good evening, Professor. We are waiting for the presenter.
Can you hear me?
Yep, sure.
Okay. So hi everyone. Thank you for taking the time to join us today, especially in the middle of your top schedule. My name is Ho-Sik Sin, the prologist at Goshin University Gospel Hospital, and I'll be serving as the moderator for today's lesson. It's great to have you here. We will now move on to chapter 13, the kidney transplantation and liver disease. Dr. Swanara will be giving the presentation around 15 minutes, and I will follow up with a few additional comments afterward. Dr. Swanara, please go
Hello.
ahead.
Hello, Professor. Can you hear me?
Yes.
Perfect. I'm trying to share the screen, but I think the laptop got issue. It cannot share it out. Mình Hoi, can you help me share the screen?
Okay, Bong.
Okay. บุพาพอลกดพญาเตยmình Hoi. I'm sorry, Professor, for the delay because we are trying to share the screen. Mình Hoi cho bạn ổn.
កំពុងចូលបង
Okay, good. Actually, it's a short presentation. It take roughly around 15 minutes. So I try to, because we have never have like the actual experience on kidney transplant and liver disease patient anyway. So I've tried to more cover the theoretically stuff, and I hope to see the feedback and sharing experience from Professor Shin, Professor Ho, Sik Shin, and Professor Moon also. Hello, Professor Moon.
Good to see you.
Yeah, good to see you too. Mình hơi bị down.
Bị xóa rồi.
Okay. I can see your lecture slide. Okay.
Okay, it's perfect. Tới mục tiết hơi. So I start my presentation right now. So today I got one small presentation related to the kidney transplantation with liver disease patient, because now the increasing prevalence of the patient that need to do the dual organ transplantation is going up every time. And the last decade, we can see there's a lot of peak of the patient with dual kidney and liver transplantation is going up, and especially for the patient with already had the liver disease or infection disease like hepatitis B, hepatitis C, that can complicate it into nephropathy related to the hepatitis also increasing. That's why the prevalence of the patient that need to do transplantation kidney and the liver is going up so high. So in my presentation, we'll be covering some small remarks on it, and I hope to see the feedback from Professor after the presentation. Next, please. So as you can see, the epidemiologies of the hepatitis B and C is a lot of patients that suffering from those kind of disease. If you take a look at the data from WHO in 2022, you can see the burden case of the all hepatitis is 304 million patients worldwide. The incidence is 2.2 million, and the death related to the hepatitis B and C in 2022 is 1.3 million. It's very dangerous, and there's a lot of patients suffering from this. And hepatitis B itself, the prevalence is also not bad because it's 254 million, equal to 3.3% of the world population that got infected by the hepatitis B. And at that time, the mortality rate is 1.1 million patients, and hepatitis C is 50 million, equal to 0.7% of the world population, and the incidence of mortality rate is 240 million in 2022. Next. So why is it related? Because there are some kidney disease can be related to hepatitis B or hepatitis B infected, or sometimes related to the complications of the disease itself, like hepatorenal syndrome, membranous nephropathy that related to hepatitis B infected, or membranous proliferative glomerulonephritis that mostly related to hepatitis C virus infected. And sometimes the co-infection and immunosuppression will pose additional problem to the kidney transplantation. As you can see, when you use the immunosuppressant medication, it will lowering down the immune system of the patient. It will hyper up the viral loads of the hepatitis, and it causes another problem related to the infection disease. The chronic hepatitis and cirrhosis is another issue because there's a lot of patients that develop from chronic hepatitis, develop to cirrhosis, and can develop to liver dysfunction. And then at the same time, they might need they might add the complexity to the transplantation procedure. Next. So in general consideration, we have to measure, we have to calculate the severities of the disease. That for right now, we have the score, we call it MEL score and childhood score. The MEL score is a score that we use to evaluate the gravity and the priority, the needed of the liver and kidney transplantation in the patient that's already have liver disease. The childhood score is, I think most of us know childhood score already. It's the score that will calculate the severity of the liver, especially in cirrhosis patient. So those kind of score will give you the idea. How do we select the patient and how do we select the procedure for the patient? Should this patient do just the kidney transplant, or they have to do the SLKT? SLKT means simultaneous liver kidney transplant. It means that they have to do both organ transplantation at the same time. And the risk of the hepatocellular carcinoma, the infection, the graft failure also need to balancing before we decide which procedure that we have to do for the patient. Next, please. So what is the MEL score? The MEL score is a score that designed in 2026 by Mayo Clinic that used to predict the severity and the priority of the patient that need the dual kidney transplantation and liver transplantation at the same time. The MEL score, they have a lot of criteria to put it, but at the same time, they keep on developing. In 2026, they don't put sodiums in that, and at 2022, they put sodium in this calculation also. So the parameter that you need to calculate the MEL score is creatinine, bilirubin, ENO, and sodium. And it will calculate into the score for the patient. When the score is more than 25, it means that the priority of the kidney and liver transplant at the same time is more priority because it predicts the severity and the needed for the liver transplantation for the patient with chronic kidney disease and liver disease. Next, please. And this is the childhood score. The childhood score is a score to calculate the severity of liver cirrhosis patient. And the criteria to evaluate the parameter to evaluate the childhood score, we need the total bilirubin, the sodium albumin, serum albumin, prothrombin, ENO, acid, and patient hepatic encephalopathy. The score will classify into three categories, A, B, and C. The A is the lower severity score. The B is a moderate, and C is severe score. Next, please. So why is hepatitis B is challenging for the patient with kidney transplant? Because the risk of hepatitis B reactivation post-transplantation is should be consideration, because when we use immunosuppression for the patient that already infected by hepatitis B, and as you can see, the seroconversion, it means the curable of the hepatitis B is very low. So when you use the immunosuppression on the patient with already have the chronic hepatitis B but not curable, it means that they don't have the anti-HBF antibody to protect the cell. They have a chance to reactivate the hepatitis B infected. So at the same time, the patient might have suffering from the active hepatitis B. So the management is to make the viral load undetectable pre-transplantation. And for prophylaxis, entecavir and tenofovir is the medication of choice that we can use it. And after the transplantation, we have to do the monitoring of the hepatitis B DNA monitoring, like PCR testing. Transplant consideration for hepatitis B with compensated liver disease may undergo kidney transplant alone. It means that if the male score is under 25 and the childhood score is at 8 category, so we can consider only just kidney transplantation and follow up the liver disease after transplantation. But if the male score is more than 25, or the score of childhood of the patient start from stage B or C, it means the severity of the patient is really high. So the need of dual kidney and liver transplantation is high. So they recommend is to do the SLKT for those kind of patients. Next, please. So according to the KDIGO 29 guideline that I only have in hand, they suggested that any currently available induction and maintenance immunosuppression medication can be used in hepatitis B infected kidney transplant recipient. They suggest interferon treatment because at that time, interferon treatment is the medication of choice, because in 2009, the interferon is the medication of choice to treat the hepatitis B infection for kidney transplantation. But right now we have tenofovir and entecavir also recommended to use in those kind of patients. They suggest that the patient with HBs antigen positive kidney transplant recipient should receive prophylaxis with tenofovir and entecavir or lamivudine. But lamivudine might give another problem, because as you can see, the lamivudine is not a medication of choice, because it will produce another problem for the patient after kidney transplantation if you use lamivudine as a first choice therapy. So that's why they recommend tenofovir and entecavir as a first choice therapy, and then lamivudine in case of tenofovir or entecavir resistant or is not available. After that, the screening for HBs antigen positive patient with cirrhosis. And then we have to screening for hepatocellular carcinoma every 12 months after kidney transplantation. Also, at the same time, we might have to check alpha fetoprotein. They suggest the patient who have negative for HBs antigen and have antibody, HBF antibody, should do the vaccination regularly to make sure that they have the protection from hepatitis B. Next, please. How about hepatitis C infection patient? So hepatitis C, before there is no curable, but right now we have a really simple method to treat the patient with hepatitis C. Before we use interferon injection plus another oral medication. But right now they have oral medication that really effectively and treat the patient just for 3-month treatment. So, but for hepatitis C infected, the outcome is poorer than hepatitis B infection. They will accelerate the liver fibrosis or cirrhosis for the patient. And there also another problem is hepatitis C related glomerulonephritis, like membranoproliferative glomerulonephritis that develop really fast. And also immunosuppression might worsening the viral load of the patient if the patient is not cured yet. The management is we do direct acting antiviral to achieve the curable rate. As I mentioned earlier, hepatitis B is the curable disease. And the duration of the treatment and the medication of the treatment is not really complicated like before. And we have to do the treatment, make sure that they have the curable rate more than 95% before transplantation, if possible. For transplantation, the criteria is not different from hepatitis B. The patient have the MERS score under 25 and the Charles-Put score is an A category. It means the severity is low. We just do the kidney alone transplantation and follow up the liver function after transplantation. If the patient have the MERS score more than 25 and the Charles-Put score is B or C, I mean the severity is so high, the demand of the dual organ transplantation is high. So the recommendation they suggest to do the simultaneous liver kidney transplantation. Next, please. So this is the recommendation from KDIGO. It's not really different from the presentation earlier. All right, we skip that because we have time limited. Next, please. What about liver cirrhosis patient? As I mentioned earlier, if the patient got liver cirrhosis already and they are needed the kidney transplantation, we have to check for the severity score of the patient. First is the Charles-Put score, second is the MERS score. So if the Charles-Put score of the patient is the child A and the MERS score is under 25, so they recommend to use only kidney transplantation alone, and we have to follow up the liver function and the activity of the liver disease after transplantation. But if the patient have decompensate liver cirrhosis, I mean they have the score of Charles-Put is child B or child C, and the MERS score is more than 25, they recommend to do the dual organ transplantation, liver and kidney at the same time. So when should we select? Why we consider severities like that? Because before, when the patient they have liver disease, they in the state of liver cirrhosis or not liver cirrhosis, people always wait to do the dual organ transplantation because they expected the outcome is better than they do the simultaneous kidney transplantation alone. Because when you have two organ transplantation at the same time, when you got two diseases at the same time, you expect the outcome is better than you do just kidney transplantation. But the problem is the SLKT waiting list is really long, and the development of the complication of liver disease is something that we cannot predict. So that's why we do a study to compare. When the patient have the compensate liver cirrhosis with the MERS score under 25 and the Charles-Put score only child A, they don't need to wait for simultaneous liver kidney transplantation. They can do just kidney transplantation alone, and it's easier to find the donor. Next. And the outcome is shown already for the patient that doesn't need to wait for SLKT transplantation, I mean dual organ transplantation. They have recovered better than the patient who are still in the waiting list, and most of the patients in waiting list, some are die, some develop some complication like encephalopathy, hepatitis, some got acidic that will pose another complication to the transplantation procedure. So that's why at the end, they recommend for the patient who have compensated liver cirrhosis, it means they have MET score under 25, child post score is child 8, don't need to do the SLKT, just do the kidney transplantation alone. But for the patient that have more severity, they have to wait for the dual organ transplantation. Next, please. So what is simultaneous liver kidney transplantation? SLKT is indicated for the patient who got liver dysfunction. It means they liver really cannot, the cirrhosis is decompensated. They cannot compensate it by any medication anymore. If you take a look at the MET score, normally those kind of patients is MET score more than 25. And the challenging is when you do the two organ transplantation at the same time, you will increase the risk during the procedure, and you need a really good team to participate at the same time. And the outcome of the patient is better if they can have two organ transplantation, but the problem is the waiting list. You have to wait a really long time to have a dual organ transplantation at the same time. And mostly in Cambodia, our first procedure that we start from living organ donation. So we don't do disease donation yet. So for living organ donation, when you need two organs at the same time, that will be really challenging. So if you take a look at the immunosuppression, as I mentioned earlier, when one patient, they got infected by hepatitis B or hepatitis B, and they not cured yet. It means they still have the disease, but it's not activated. When you do the transplantation, you have to introduce the medication to the patient that suppress the immunity of the patient, and then at the same time, it's just like you waking up the disease that has been slept for a very long time to reactivate again. That will cause another problem, like infection problem for the patient. So CNI is the one that we have to be really careful, because it might worsening the liver function when the patient already have the liver disease, or the function of the liver is not really good at the same time. And we have to really select it, some other medication that metabolize at the liver. Mycophenolate is one that should be liver friendly, and CNI, as mentioned earlier, it should be precaution. We can still use it, but we have to monitor it at the same time. And I also have a question posed to Professor Ho's 16 already about the alternative immunosuppression in case the patient have liver dysfunction already. Next. So for monitoring post transplantation, for kidney function monitoring and everything, I think our college already have discussed it in other presentation already. I highlight only focus on the liver monitoring, because I think the infection issue is something that regarded to the presentation, and also the liver function of the patient is something that we are focused on. Hepatitis B's DNA and antigens, HBs antigen level have to be regularly evaluation and check up regularly after transplantation. Also, ONA of hepatitis C for relapsing or reinfected of hepatitis C should be treated or should be monitoring regularly. Liver function test, imaging test to see the liver function and the image of the liver also have to be followed up. And monitoring for HCC, hepatocellular carcinoma, in cirrhosis patient has to be followed up all the time also. I forgot to add the alpha-fetoprotein in those kind of patients. We have to check up quite routinely also. Next, please. So in conclusion, the kidney transplantation in liver disease patient is feasible, but it's quite complexity. We have to better management the patient before transplantation, and we have to select the criteria which procedure that we have to use for that patient, just for the kidney, or we have to do the dual organ transplantation at the same time. Hepatitis B and hepatitis C are no longer absolute indication with more than antiviral, or it's not a indication for transplantation also. As LKT improve the survival rate in some selected patients that need dual organ transplantation, but the waiting list is an issue. And for living donor transplantation, it might pose some challenging, especially in Cambodia. And thank you for your attention.
Thank you, Dr. Savanara, for that clear and informative presentation. So I will share a few brief comments.
Yes.
1 second. Can you see my slide?
Yes, clearly, Professor.
Thank you.
See.
I think that this talk that gave us a really clear overview of how far we have come, particularly with the use of antiviral and the evolving role of simultaneously liver kidney transplants. When it comes to the kidney transplant in patients with liver disease, there are a few key things to keep in mind. So liver problem can actually lead to kidney failure. So evaluating the liver's condition is critical. So the transplanting timing. In some cases, the patient may need both kidney and liver transplant from the deceased donors. And after transplant, it's all about the careful monitoring, managing the new organ, adjusting the medication, and watching out for infection. There have been some great updates in kidney liver transplantation. Using combined the risk scores is helping doctors better select patient and improve the outcomes. Living donor, the kidney transplants are also on the rise with more focus on keeping donors safe. But there are still challenges like managing complex immunosuppression and dealing with complications like hepatorenal syndrome. More research is also needed to understand long-term results and improve the precision treatment. When we are dealing with both kidney and liver disease, there are the 4 key phases to think about. First, we have got to assess how well both organs are working. Next, patient selection has to be handled with care. Then getting the timing of the transplant just right is super important. And finally, after the transplant, the patient needs solid follow care from multidisciplinary teams to make sure things stay on track. 1 second. I already received the question from Dr. Savanara about the immunosuppression medication. So the question is that a question related to immunosuppressive medication for kidney transplant. Patient with liver function really down. Any other immunosuppressive medication besides the calcium unit inhibitor we can use as we knew CNI is not really good for liver disease function patient. It's very difficult to us for the kidney liver disease in the transplantation. After I researching the article, so if a kidney transplant patient has really poor liver function, a CNI-free regimen like MMF alone or belatacept-based therapy. Only the belatacept is not available in our country, or mTOR inhibitors can be good option.
Yeah.
Listen to studies how they are generally safe and effective with the MMF and belatacept being the most promising. When we select the mTOR inhibitors, so the transplant the kidney function is good. It means maybe eGFR more than the 60 ml per min and no proteinuria. It's very important. That's it. So any other question or comment, please?
Thank you so much, Professor. That's really wonderful. So we have the alternative way to do that. Keep in my mind already that mTOR or belatacept or something that we can use instead of CNI if those are available in Cambodia.
Yes.
Oh, this is Dr. Moon speaking. Can you hear me?
Sure, Professor.
Okay. Concerning about the combined kidney and liver all together, one time, simultaneous liver and kidney transplantation, I had three cases before my retirement. At that time, the liver pathology is hepatocellular carcinoma, which is Milan criteria, within the Milan criteria. And the patient has some kidney failure because of some kind of, hepatocellular carcinoma treatment for chemotherapy or something. They hit the chemotherapy agent hit the kidney. So at that time, kidney from the deceased donor and the partial liver transplantation from the neighbor, so family members. So combined all together in one time. That is my experience of the simultaneous kidney and liver transplantation in Catholic University. And concerning about the immunosuppressive agent, the liver transplantation, the immune suppression is not so strong. For the kidney transplantation, the liver, the immune suppression for kidney is very strong.
Liver.
So just like some liver is a sponge-like and kidney like some stone-like, so stone-like is more strong. So always follow the kidney the protocol. That's what I still remember, the number of amount of the immunosuppressive agent. That's all I have to say here. And I'm very thank you for some comment, Chinosik Doctor and Sonorama. It's good to see all the guys here. Thank you.
Thank you, Professor. Thanks for sharing.
Thank you, Dr. Moon. Thank you so much. You had a great comment. So,
Dr. Lebetin, you have any question?
So, good afternoon, good evening, Professor and everybody. I really don't have any question. Just congratulations for you and all the team, and especially Professor Moon that sharing his own experience.
Professor Moon, may I have one question, please?
Okay.
Regarding to your examples or one of your last patient that got complication from hepatocellular carcinoma related to the medication, can you tell me what kind of medication that he used and caused the problem to the kidney?
It almost 10 years ago, so I almost forget the immunosuppressive agent. So the first case, still I remember, which one, liver first and then kidney? Which one will be the first? Kidney first and liver? Which one will? So for the first time, kidney first, and some fluid therapy is much easier. So the first case is kidney first, and the second one, maybe I had a experience of 3 or 4 times of simultaneous liver and kidney, and second time, why don't you try to vice versa? So liver first, it will take a long time, and then kidney. So it is controversial at that time. I'm not sure for this time of year, maybe change it and some guideline for the simultaneous liver and kidney transplantation one time, but I have no idea about that. So sorry to I forget almost every immunosuppressive, drug amount or something. Sorry.
Thank you. Thank you for sharing.
Anyway, kidney first will be much better. I think it will be, much small, short time, and then the fluid therapy will be much easier.
Thank you. Thank you, Professor.
Professor
Shin, I have one question.
Yeah.
As your idea, since we are not starting our transplant program yet, and related to our current situation right now, do you think is there any possibility to do the transplantation with hepatitis B or hepatitis C positive patient?
Yes, this is a good question to me. I think you means you are not starting the trust program. Yeah, I
Yes.
understand. So I think before the starting the transplantation with hepatitis B or C, I think you should perform this hepatitis B negative and hepatitis C negative transplantation first. And after, you should try to
The positive patient.
hepatitis. Yeah, I recommend you.
Yeah, thank you.
Yes, thank you for a great presentation and great comment from Dr. Savanara and Dr. Moon. Thank you so much.
Thank you. Thank you,
So I
Professor.
think, I hope that this talk spark more conversation among us about how we can improve the outcomes in this challenging population. Thank you again to everyone for joining us. We look forward to seeing you all next Tuesday afternoon.
Thank
Thanks so
you.
much.
Thank you. Thank you. Thank you, Professor.
Bye there. Bye there.
Thank
Bye-bye.
you.